Professor Wanner, the renal data of the EMPEREX study have been discussed here in Madrid at the ERA EDTA Congress. So, yeah, what can you report on this? So, what is the outcome? What are the renal outcomes of the EMPEREX study?
So, if you give empagliflozin to a patient with diabetic kidney disease, but not only with normal kidney function, but also with impaired kidney function, and this is new, you get a reduction in the progression of diabetic kidney disease, and the reduction is substantial. And this was not expected, and it took some while that the nephrological community so-called digested the results, get used to, and understand the different levels of protection. It was not designed as a renal outcome study, it was designed as a cardiovascular outcome study, and the renal endpoints are secondary endpoints. However, the result is so overwhelming in reduction of macroalbuminuria by 39%, halvening of the risk to go to dialysis, or in combination with doubling of serum creatinine. So this result is so spectacular after 15 years of blood pressure reduction and treatment with RAS blockade, that it was a surprise by nephrologists, and they now get used to the data, and I think they all also want to see confirmation with the next trial and new data.
So you're planning a next trial?
We are hoping to get a new trial.
Yeah.
We are very close to get the new trial because there's so much interest in it, and there is funding opportunities. And the next trial would not only be diabetic kidney disease, but also non-diabetic kidney disease. So any type of progressive chronic kidney disease would be of interest. The hypothesis is a reduction in hyperfiltration, normalization of intraglomerular pressure, and I think this, for nephrologists, is after using RAS blockade, a known principle. They rapidly now adopt this therapeutic principle and chance. And I hope when we get the trial, everybody will participate.
Okay, so we hope as well. Just let me ask you another question. For now, we don't have this trial yet. So, but what about the patients who are diabetics and have CKD? Do you think the evidence is good enough that everyone should receive this medication now?
From a regulatory standpoint, from statistics, it is the first trial, it is a secondary endpoint, and I think for many people it should be, first of all, confirmed this result, and it should be stronger by seeing the primary endpoint being a kidney endpoint. Therefore, we still have obstacles. We have no label for treatment below estimated GFR of 60. We have to stop the drug at 45. Already we have so much evidence also from other SGLT2 inhibitors, more or less canagliflozin, dapagliflozin, show already data which go in the same direction, that we can believe already in this treatment. Of course, it is a new treatment, and it's a huge hope that we can further reduce the progression, that many doctors already are pushing quite hard, more or less off-label in this direction. And but wait, if you have so much experience over the years in medicine, you really many want to see a confirmation. And in about 9 days from this interview, so when you release this interview, maybe it's already known data from the next large trial, which with canagliflozin will be presented, and then we have a better feeling, I think.
Okay, Okay, so let's wait 7 days at least.
7 days at the American Diabetes Association. I'm sure these type of trials will come up in the media, press, and in journals at the same hour, and everybody can see them. And I personally, I hope that we get positive and good results, because it's good for the class. Maybe we don't like to talk about class effects, but it's good for the patient and for the field. We can move the field ahead. If with other SGLT2 inhibitors, and I think we will see the same, and if with other SGLT2 inhibitors can be shown the same thing.
Yeah, okay, thank you very much.
Thank you.